Good afternoon, welcome, and thank you for joining us today for a Lunch and Learn webinar about clinical tools for care of ME, CFS, POTS, and fibromyalgia. We're presenting this webinar today in partnership with CareNow Ontario, and I'll be introducing our CareNow speakers in a moment. First of all, a little bit of housekeeping. You will notice that your microphones are muted and they will remain muted throughout the webinar. If you have questions about the content that you're hearing, please post those in the Q&A panel. This will allow others to upvote your questions, and that in turn helps us to prioritize what's important to the group when we're moderating them. If you have technical questions for Alliance staff, please post them in the chat window, and either I or my colleague Cynthia will respond to those and help you out. As usual, we are recording this webinar, and we will send an email out in the next few days with a link to the recording and slide deck. Oh, I'm seeing from somebody saying that they cannot hear. Can others just maybe give a thumbs up if you can hear me? So I'm seeing lots of thumbs up. So Cynthia, perhaps you can connect with Karen in a personal message and see if you can help her sort her audio problems. So as mentioned, we are recording this webinar. We will send out an email in the next few days with a link to the recording and to the slide deck. Please turn off any AI-enabled note takers or recording devices, and we will be manually removing from the webinar any bots that we see in the participant list. So with that, I'd like to take a moment now to acknowledge this land, its Indigenous stewards, and our presence on it. We recognize that the work of the Alliance for Healthier Communities and Alliance members takes place across what is now called Ontario on traditional territories of the Indigenous people who have lived here since time immemorial and who have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario today continues to be home to vibrant and diverse Indigenous communities who have distinct and specific histories, needs, and assets, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding responsibilities to all who now live on these lands, to the land itself, and to the resources that make our lives possible. My name is Catherine, and I'm descended from people who came to Turtle Island as colonial settlers. I was born in Halkomelem territory, and I have lived and worked in the lands of many Indigenous peoples. I'm currently situated in Toronto, the treaty land of the Mississaugas of the Credit, and the traditional home of many Indigenous people, including the Anishinaabe, Wendat, Chippewa, and Haudenosaunee peoples. Our presenters today are Dr. Farah Tabassum, who works at the Environmental Health Clinic at Women's College Hospital, and Kathleen Dennis from CareNow Ontario. Some of you may also recognize another familiar face online, Adriana Tetley, former CEO of the Alliance for Healthier Communities, who is also a board member at CareNow Ontario, and who has been passionate about care for these under-recognized and underserved chronic illnesses for a very long time. Dr. Tabassum is a family doctor in the Environmental Health Clinic at Women's College Hospital. She also has extensive experience practicing in community health centers, having worked for 14 continuous years at a single CHC and several years of locum work at multiple other ones. Kathleen Dennis is a retired nurse and a lived experience patient partner with CareNow Ontario. She contributed to the development of the tools you'll be learning about today. And with that, I will turn you over to Farah.
Great. Thank you very much, Catherine, for that introduction. Just going to share my screen. Perfect. Great. So good afternoon, everyone. I want to say thank you to the Alliance for Healthier Communities for inviting us to speak today, and to all of you for joining us to learn about a new set of clinical tools for primary care clinicians on the topics of ME, which stands for Myalgic Encephalitis, formerly known as chronic fatigue syndrome, POTS, which is short for postural orthostatic tachycardia syndrome, and fibromyalgia.
Farah, I am sorry to interrupt. I don't think the screen share worked. Can you try it again?
Is anyone else able to confirm that? Because I see it on my screen as having shared. Kathleen?
I can see it.
Others are seeing it, so Zoom is just doing me dirty today. Go ahead.
I can
No
see it.
problem.
Okay.
Okay. So this is the landing page for the Center for Effective Practice Tools for Primary Care on the topics of fibromyalgia, ME, and POTS. And what I want to highlight are the blue rectangular tiles on the right that have each of the three diagnoses uniquely listed but grouped together, emphasizing their overlap. Within the Center for Effective Practice tool, each of the three conditions are set up pretty similarly, with a section for clinical presentation, another for clinical presentation and diagnosis, another one for assessment, and a separate one for management. The web page can be directly accessed through the QR code on the bottom right of the slide. And also of note on the main page of the website is that there is a section for additional resources on each of the three topics, and there are separate ones specifically for caregivers and patients and separate ones for clinicians. So in terms of objectives, one of our first objectives for today is to determine how to diagnose and prioritize management for ME, fibromyalgia, and POTS. Second is to understand how management changes if the conditions are comorbidly present. Thirdly, to apply the tools from the Center for Effective Practice to support diagnosis and management of all three of the conditions. Fourthly, to learn about disability-related supports that can be helpful and how interprofessional healthcare providers can be of support in patient care. And an overarching goal that we do have for everyone is hopefully that after hearing this presentation, there'll be more comfort in adding ME, fibromyalgia, and POTS to the differential diagnosis list.
Good afternoon, everyone. Thank you again for joining us. I'm just going to choose to turn my camera off so I can actually see my notes a bit better. Before we get into the details of the topics, we'd like to highlight two patient cases, and you might even recognize similar patients in your own practice. These cases are simplified for learning purposes. At the end, we'll return to the cases to show you how you might use the tools we discussed today to approach patients with similar symptoms. Our first case is Kat. In this case highlights a fairly classic presentation of an acute infection progressing to a prolonged post-infectious illness consistent with ME. The patient was previously healthy 51-year-old female who initially developed a headache, fever, and a maculopapular chest rash 6 days following mosquito bites. Over a short period of time, symptoms progressed significantly to include severe headache, photophobia, profound fatigue, upper body muscle weakness, and episodes of disorientation. The fever and initial acute symptoms resolved over a 3-week period, and while the patient technically was able to return to work, she never truly recovered to her previous baseline. Persistent symptoms included severe fatigue despite sleeping 12 to 14 hours per night, cognitive dysfunction or brain fog, orthostatic symptoms including lightheadedness on standing, dizziness, palpitations, and diffuse musculoskeletal pain. This is an important teaching case because many patients with ME report a clear infectious trigger followed by incomplete recovery and development of chronic multisystem illnesses that are often initially missed or misunderstood in the healthcare system. And our second case is Bridget. Bridget is a 52-year-old female with a long-standing history of chronic pain after an MVA. She initially had pain in her neck and shoulders and later developed pain in her arms, legs, and lower back. Over the years, she had numerous workups, inflammatory markers were negative, and imaging has always been normal. So historically, she was diagnosed with fibromyalgia, but despite appropriate pharmacological management for fibromyalgia, she reports ongoing uncontrolled pain, poor sleep, and debilitating fatigue. So over the course of the next 45 minutes, think about how you would approach a diagnosis and the management of these patients, and we'll come back to them at the end.
Great. Thank you, Kathleen. So we have 6 main sections to cover in today's presentation, as outlined above in the slide. In the first half, we're going to introduce the 3 conditions, ME, fibromyalgia, and POTS, and in subsequent sections, we will specifically discuss fibromyalgia, ME, the difference between those two, and then end with a short discussion on POTS, as well as the role of interprofessional teams supporting care. And finally, we will end with the case discussions and touch upon helpful disability supports and the potential role of interprofessional teams. So what are ME, fibromyalgia, and POTS? So starting with ME is characterized by symptoms of profound and debilitating fatigue, cognitive dysfunction, sleep abnormalities, often with autonomic manifestations, pain, and other symptoms. And these symptoms can be made worse by exertion, which can be physical, cognitive, emotional, or orthostatic in nature. Fibromyalgia is characterized by widespread musculoskeletal pain, as well as other associated symptoms such as sleep disturbances, fatigue, impaired cognition, and physical function. Symptoms often vary from person to person, and within the same individual can fluctuate day to day. Postural orthostatic tachycardia syndrome is a form of dysfunction of the autonomic nervous system, and it is characterized by symptoms of excessive orthostatic tachycardia and orthostatic intolerance. And I do want to highlight that all 3 conditions are commonly comorbid, and all 3 conditions are also more common in women. So why learn about this? These illnesses, unfortunately, are still not commonly taught in medical school or residency, and many patients remain undiagnosed or poorly managed. These conditions can lead to quite severe disability and poor quality of life. These conditions are also often found in the post-infectious setting. And with the recent pandemic in mind, this becomes even more relevant, as we know that approximately 20% of people who experienced an acute COVID infection, especially in the early years, 20% of them went on to have longer-term symptoms beyond 3 months. And of those 20%, about 50% were meeting diagnostic criteria for ME. Family medicine is optimally positioned to recognize the constellation of symptoms that come from the involvement of multi-organ system conditions, and are uniquely positioned to tie the whole person picture together to then diagnose and offer management for these conditions. Our hope for this group today is that after listening to this presentation, that there will be an increase in comfort and confidence to recognize, diagnose, and implement management strategies to help your patients with these conditions. So why are the 3 conditions, ME, fibromyalgia, and POTS, challenging to diagnose? First off, there is no specific diagnostic laboratory or imaging test for these conditions, and they are all multi-system disorders with varying degrees of severity, as well as varying combination of symptom clusters. Within the conventional medical model of care, there tends to be a division of care by specialty based on organ system involvement. And this unfortunately has created silos of care, with no single specialty area of medicine adopting these conditions as being under their umbrella for care. So just to further highlight complexity, this is the Canadian consensus criteria to help make a diagnosis of ME. And what we see, there's multiple categories, multiple symptoms listed here. And my colleagues and I asked the question, if we assigned each symptom from the Canadian consensus criteria to their respective specialty and specialist, how many specialists could a patient technically see? And if you want to garner a guess while I change over slides, the answer to that is actually 17. And so again, highlighting the complexity of these conditions. So we're now going to move on to how to diagnose and manage the three conditions. These are huge topics, and we are really only getting at the tip of the iceberg. And so we definitely encourage everyone to please go to the Center for Effective Practice Tools for more details, as well as looking at the incorporated links in the tool. We are going to be starting our discussion with fibromyalgia, as it has become more familiar and known over the last 1 to 2 decades and is often diagnosed in primary care or chronic pain clinic settings. So in terms of onset can be gradual or it could be sudden. The history that one wants to listen out for is it's often after a period of physical or psychological stress. In terms of physical stressors, often after a viral infection, some sort of accident or injury, such as a motor vehicle accident, or some type of surgical intervention or operation. However, sometimes no specific stressor is easily identified. I do want to mention that from my clinical experience, I would say that the most common history I hear is onset after a motor vehicle accident, followed by viral infection, and then followed by women who are postpartum. Secondly, in terms of epidemiology, fibromyalgia disproportionately affects women, in the range of about 80 to 90% of patients being women. Typical symptoms include widespread pain, fatigue, poor sleep, cognitive difficulties, plus other symptoms such as sensory sensitivities, headaches, as well as mood symptoms. In terms of investigations to consider, one might want to do baseline CBC, do some inflammatory markers, liver function testing, thyroid function testing, and a metabolic workup. One also would want to evaluate for conditions that can worsen pain, such as the presence of sleep disorders or any changes or new medications, such as lipid-lowering agents. Just want to provide a reminder here that fibromyalgia is not a diagnosis of exclusion, and so it can exist with other conditions such as autoimmune and rheumatological conditions. And typically, if a patient's inflammatory markers, the ESR and CRP, come back elevated, for me, that's always been a red flag to search for and rule out other inflammatory diseases such as IBD, rheumatoid arthritis, lupus, or other connective tissue disorders. So next, we're going to go through how to make a diagnosis using the 2016 fibromyalgia diagnostic criteria. This slide just shows you what it looks like in its entirety. It's divided up into 3 sections. The first part of this is the widespread pain index. The second section is the symptom severity score area. And then finally, there is a section for scoring. And in clinical practice, I often give this to patients to complete on their own, and then they send it back. I do the scoring, and then we review it together. So the first section asks that the patient check off in the past week all of the regions that they have experienced pain, and it's divided up into 5 pain regions. A clinical pearl from this slide is that patients may not describe widespread pain when initially asked, so it is important to directly ask about pain felt elsewhere in the body. Moving on to the second section, the symptom severity score, it's divided up into a first part that asks about symptoms of fatigue, symptoms of refreshing sleep, and thirdly, cognitive symptoms. And those 3 symptoms, the patient rates it on a scale of 0, meaning it's not a problem at all the way up to 3, meaning it's severe, pervasive, or life-disturbing. And then the second part of the symptom severity scoring section is 3 questions, one about yes/no questions, one about headaches, one about the involvement of abdominal pain or cramps, and then the third one about mood symptoms such as depression. So in terms of diagnosis, criteria 1 is met if the patient has a widespread pain index score greater or equal to 7, plus a symptom severity score greater than or equal to 5, or the patient has a slightly lower widespread pain index in the range of 4 to 6, accompanied by a slightly higher symptom severity score of 9. The second criteria is that the patient must have generalized pain, meaning that they checked off that they're experiencing pain in 4 out of the 5 regions in that first section called the widespread pain index. And finally, symptoms need to be present for greater than or equal to 3 months. And I just want to mention here that in terms of a clinical pearl, that the presence of tender points are not needed to confirm a diagnosis. Those were dropped from the criteria sometime around 2010. So once you have a patient who meets criteria for fibromyalgia, what's key here is that before moving on to a management plan, it's really critical to back up and revisit how did the patient score their fatigue level in the symptom severity scoring section. And to my knowledge, the Center for Effective Practice tool is really the first tool that highlights taking into account the impact of the presence of possible comorbid conditions. And so the clinical pearl from here is that if a patient notes anything more than mild fatigue, meaning if they scored anything greater than a 1 on this diagnostic worksheet, that patient really needs to be screened for ME. As if both conditions are present, it does change management. And we're going to go into that in a little bit further detail further along in the presentation. So just speaking about the patient who solely has fibromyalgia, there are non-pharmacologic and pharmacologic approaches. Non-pharmacologic approaches includes providing patient education about chronic pain, providing support for mental health and well-being and coping with a chronic illness, adaptation, addressing grief and pain. There are also complementary and alternative therapies such as acupuncture and massage. And then there are physical and occupational therapies that can be helpful as well. And I do have a clinical alert here. This is directly from the Center for Effective Practice tool, again, kind of taking into consideration the potential comorbidities. And it says, in patients with coexisting conditions such as ME, functional and exercise limitations must be considered in program design. And as I mentioned, we will be going into that in a little bit further detail. In terms of pharmacological management, this is again further detailed. There's more detail in the Center for Effective Practice tool, but in a nutshell, there are anti-epileptic agents, SNRIs, tricyclics, weak opioid analgesics, as well as off-label medications such as low-dose naltrexone. Clinical pearl from this slide is many patients have sensitivities to medications, and therefore it is really important to start with the lowest available dose and to up-titrate very slowly to efficacy based on a patient's tolerance and limitations. So next we're going to move on to discuss ME, myalgic encephalomyelitis. So how does one go about diagnosing a patient with ME? There currently is no biomarker to diagnose ME, so it is a clinical diagnosis. And like fibromyalgia, you may use imaging or blood work to rule in or rule out other differentials based on clinical judgment. Also of note is that ME is not a diagnosis of exclusion. To guide diagnosis, there are two main diagnostic criteria that are used. Both are recognized worldwide and used by clinicians and researchers. The one we will focus on today was created by the Institute of Medicine in the US, and it was published in 2015. It is the criteria used by the CDC and outlined in the Center for Effective Practice tool. You should also, however, be aware of the Canadian consensus criteria, which was published in 2003. It is more detailed and can be beneficial for recognizing comorbidities. And we will highlight the Canadian consensus criteria at the end of this section when we are discussing comorbidities. So the Institute of Medicine has 4 core requirements, the criteria. The first is the inability to participate in activities that were possible before the illness, that have lasted for at least 6 months and is accompanied by profound and debilitating fatigue. Secondly, the symptom of post-exertional malaise, which we call PEM for short, are present. PEM is the hallmark symptom of ME, and we are going to be reviewing PEM in more detail in the next couple of slides. Thirdly, there's unrefreshing sleep. And finally, there's either the presence of cognitive dysfunction, such as impaired memory or concentration, or the presence of symptoms of orthostatic intolerance. And finally, in addition, the symptoms must be moderate to severe and must be present for at least 50% of the time. So on this slide, I want to highlight the wide spectrum of ME severity. We know from the literature that 75% of patients with this diagnosis are unable to work and 25% are homebound or bedridden. What I want to highlight here, though, although there is this wide spectrum of severity, mild ME is not comparable to how we describe mild for other chronic medical conditions, because even mild ME is very disabling, meaning that patients often aren't able to work or are not functioning in other domains of their life. So on this slide, we are going to go over characterizing the symptom of fatigue and how the fatigue of ME is unique. The fatigue of ME is typically described as profound, debilitating, and resulting in a significant reduction of activity, which could be both occupational and social. There is a need to characterize the fatigue and determine if the fatigue being described could be from ME. In order to do that, one needs to determine whether the patient is also experiencing the specific but unique symptom of post-exertional malaise, PEM for short, as PEM, as I mentioned before, is the hallmark symptom of ME. PEM is a separate, unique symptom that, although is connected to the symptom of fatigue, they are not the same thing. And we are going to go through that in a bit more detail. As ME has not been formally taught as part of core medical education training programs in Canada, most graduates did not have the opportunity to learn about the concept of post-exertional malaise in training, and it really has not been a typical part of the medical lexicon. So with this in mind, we are going to spend the next 2 slides learning about what is PEM and how to recognize it. And finally, from this slide, I want to highlight that the fatigue of ME differs in this manner from the fatigue caused by other medical conditions such as thyroid dysfunction, anemia, or mood symptoms. So as I mentioned before, PEM is the hallmark symptom of ME. And it's defined as a worsening of symptoms and function after exertion, which could be cognitive, physical, emotional, and this level of exertion was previously tolerated before disease onset. Often many basic activities of daily living can be affected. For example, I'll often hear from patients that, prior to becoming ill, they may have been showering every day or every other day, but as of since becoming ill, in order to conserve energy, they've had to significantly reduce that. Onset of post-exertional malaise is most often delayed by hours or days, and it often takes days, sometimes weeks, or even months to recover, and there are some, after a particularly bad bout of PEM, who may never return to their baseline. And what's important to know and critical to know is that repeated episodes of PEM can lead to more severe symptoms and long-term functional decline. And finally, before we leave the slide, I just want to highlight this document that was put out by INES, which stands for l'Institut National d'Excellence en Santé en Services Sociaux, which is a government agency in Quebec that published an excellent resource on assessing and managing PEM for patients with ME. And this is linked in the Center for Effective Practice Tools. So in terms of assessing PEM, there is a questionnaire called the DePaul Symptom Questionnaire for post-exertional malaise. And what you'll see on the right side, Appendix A has a list of the questions, and then Appendix B has the specific scoring. And again, I give this to patients to fill out before they see me, and then we review the scoring and review the questionnaire together. What I do want to highlight from this questionnaire is question number 9, where they ask about the duration of post-exertional malaise. And in order to meet criteria for experiencing post-exertional malaise, typically PEM needs to be present for a minimum of 14 hours or longer. So now we're going to talk about management of ME, and there is a lot to cover. So again, I just want to encourage everyone to please visit the CEP tools for further details. But what you need to know from today is that the cornerstone of ME management is pacing, which is a type of energy management. And secondly, addressing and managing common comorbidities is central to also managing ME. And we also want to consider PEM in the management approaches of those different comorbidities. So what is pacing? Pacing is an energy self-management strategy that is patient-centered. The goal of pacing is to help ME patients, first off, stabilize their energy and then reduce the frequency and intensity of episodes of post-exertional malaise with the goal of hopefully improving overall quality of life and function. It essentially gives the patient the advice to live within their energy limits, but first patients must determine what's their baseline and what are those energy limits that they're starting with. Some helpful tools for pacing include the use of activity logs and symptom diaries, which can help patients develop insights into their body's unique needs and what causes them to experience PEM. There's also heart rate monitoring and other pacing techniques, such as dividing up tasks, taking regular rest periods throughout the day, and other tools for pacing. To understand what pacing is, it is also important to understand what it is not. Historically, there have been recommendations about the use of structured exercise therapy programs for ME. The term previously used was graded exercise therapy, and you may come across this in the older, outdated literature. Exercise therapy is not the same thing as pacing. Graded exercise therapy is defined as fixed, forced, incremental increases in physical activity. And by force, what I mean is that patients were often encouraged to disregard the symptoms they were experiencing, such as increased pain, increased fatigue, and to continue to push through the activity to meet the activity goal. And this is in contrast to pacing, where the focus is on managing activity, but based on current symptoms. And the emphasis really is on flexibility. We are highlighting this here for a few reasons. One is that there is no therapy based on exercise that will improve or cure ME. And in fact, what we know now is that graded exercise programs can cause harm due to triggering repeated episodes of post-exertional malaise, which you may recall that I mentioned that repeated episodes of PEM can over time lower patients' baseline level of functioning. The overall concept of graded exercise therapy was historically recommended on incorrect theories about ME. For example, there were incorrect assumptions that ME was the result of deconditioning and of exercise avoidance, which again, we know is not true. So before we move on to the next section, I just want to revisit the Canadian consensus criteria, as it is a helpful way to conduct a review of symptoms and flag what potential comorbidities may also be present and in need of further assessment. Remembering, as noted in the clinical pearl, that ME is not just about addressing ME alone, but also about addressing the common comorbidities with the goal to improve overall quality of life. In practice, what I do is I take the Canadian consensus criteria and go through it with the patient. We underline all of the symptoms that are pertinent for the patient. I do find as well that, for example, it's very helpful in terms of asking about section 4 neurological symptoms. Initially I wasn't too sure if I'm supposed to be asking about cognitive dysfunction in terms of, leaving the stove on or wandering or disorientation. But this kind of gave me the framework and language to understand that it was more about executive functioning and asking about, difficulty with focus and concentration, difficulty with information processing, categorizing word retrieval. And so that's all detailed here. And so it gave me the language about how to understand that framework as well. So we're over halfway through, and now we're going to be reviewing how ME and fibromyalgia differ as well as overlap, and how one might approach these conditions when they present together. So before we move into the details, I wanted everyone to think about what percentage of patients with fibromyalgia also have ME. So you can take a little guess in your mind. And so the answer to that is approximately 50% of fibromyalgia patients also have ME. We know from one study that ME and fibromyalgia diagnoses overlapped in 47.3% of patients. And from another study, fibromyalgia was the most common comorbid condition among ME patients, affecting 45% of study participants. So earlier we went through the diagnostic criteria of ME and fibromyalgia in detail. Now we're going to try to simplify things, and we can see from the table when we put these two conditions side by side that they share many similarities. For example, both patients may experience fatigue, both patients may experience pain, may experience sleep issues, as well as cognitive dysfunction. But when we think of fibromyalgia, we think of chronic widespread pain as the core symptom. And pain may or may not be present in the patient with ME. Whereas in ME, the hallmark symptom is the presence of post-exertional malaise, which is not present in the patient who solely has fibromyalgia. So again, if we continue to look at these two conditions in silos and thinking more broadly in terms of how management may differ between these conditions, as many of you may already know, patients solely with fibromyalgia can benefit from moderate exercise, and exercise is in the fibromyalgia guidelines and listed in the Center for Effective Practice Tools as a way to manage symptoms. ME is different because we know an exacerbation of symptoms can be triggered by physical activity, which we call post-exertional malaise. Therefore, in the patient with ME, the focus instead needs to be on pacing. So what to do if the patient in front of you has both a diagnosis of fibromyalgia and ME? And just, reminding everyone that, as you recall from the prior slide, approximately 50% of patients with fibromyalgia also have ME. If one recommends exercise, fibromyalgia, patient that solely has fibromyalgia recommends exercise, and the patient who solely has ME, there's the recommendation of pacing. What to do if a patient has both diagnoses? And the answer to that is that pacing needs to be prioritized to stabilize energy and avoid states of post-exertional malaise. And so patients should be encouraged to pace their activity within their energy limits with the goal to stabilize their energy and avoid PEM. For some patients, this may mean no formal exercise and instead focusing on managing their activities of daily living and household tasks first. So now we are now going to move into our final section to discuss POTS, also known as postural orthostatic tachycardia syndrome. In terms of history, onset is often after an infectious illness, and patients will typically present with symptoms of lightheadedness, tachycardia, palpitations, feeling pre-syncopal upon standing, symptoms of fatigue, as well as these symptoms improving with going from an upright to a supine position or recumbency. And just want to highlight here again that POTS is commonly comorbid with both ME and fibromyalgia. In POTS, there may also be the presence of a broader constellation of symptoms fitting under the umbrella of dysautonomia, such as gastrointestinal symptoms, temperature dysregulation, as well as urological symptoms. Screening for POTS involves a series of blood pressure and heart rate readings in both the supine and upright position, which takes approximately 10 minutes to complete. 20 minutes to complete. The series of blood pressure and heart rate readings are done over a period of 10 minutes, and these can be done in the primary care office setting. With respect to diagnostic criteria, the diagnostic criteria involve a greater than 3-month duration of symptoms of orthostatic intolerance that are at least partially relieved by recumbency. Secondly, during the 10-minute stand test, there is a sustained increase in heart rate by 30 beats per minute in the adult when going from a supine position to an upright position within the 10 minutes of standing. And that increase in heart rate is sustained over 2 consecutive readings. Thirdly, there's an absence of orthostatic hypotension, meaning we don't see a drop of greater than 20 millimeters systolic or greater than 10 millimeters diastolic in blood pressure. And as mentioned before, the 10-minute stand test can be used to screen for POTS. In terms of management, there are non-pharmacologic as well as pharmacologic approaches, and lifestyle measures sometimes can be enough, meaning that not all patients who have a diagnosis of POTS require pharmacological management. And again, before moving on to a management plan, Just like with fibromyalgia, one does need to do a review of systems to determine if the patient may also have ME, because these two conditions are very commonly comorbid. In a nutshell, with respect to non-pharmacologic management, on the left side, there's volume expansion approaches such as increasing fluids to 2 to 3 liters a day, increasing salt if appropriate, especially in the context, you want to be cautious in the patient who may have underlying hypertension. There's also electrolyte fluids that could be considered, orthostatic support such as compression garments, raising the head of the bed, as well as avoid prolonged standing. And then there can be activity which needs to be individualized. Patients who solely have POTS, often they're encouraged to start with physical activity in a recumbent position, such as biking or rowing, and then gradually progressing to an upright position and building tolerance slowly. But again, just highlighting there on the right side that before engaging in a physical rehabilitation program, patients need to be screened for ME. And if present, comorbidly present, that patient needs to avoid graded exercise approaches and use pacing to prevent PEM. So if patients have disabling symptoms of POTS or continue to experience debilitating symptoms after implementing non-pharmacologic therapies, strategies, one should consider pharmacologic therapies. And therapies, these are all listed in the CEP tools, are aimed to manage symptoms by improving central blood volume, enhancing vasoconstriction, and reducing sinus tachycardia. And over to you, Kathleen.
Thank you. I'm just going to remind you, I'm going to turn off my screen so that I can focus on my notes. So over the next few slides, we're going to look at the role of interprofessional care with these patients or clients. People living with these conditions often have complex, fluctuating symptoms that affect every aspect of daily life, including cognition, mobility, and the ability to manage basic activities. So the interprofessional team members are often the ones who can identify the relatively simple practical interventions that can make meaningful difference in the quality of life and stability for these patients. In a nutshell, the interprofessional team helps translate medical recommendations into sustainable daily living strategies with the goal of preserving function, stability, and quality of life. So occupational therapy is often one of the most valuable and practical supports for these patients because they focus on the function in real life, not only the symptoms in the clinic. OTs translate medical advice into sustainable daily living. Patients are often told by clinicians to pace or manage stress, but OTs help operationalize what that actually looks like in a patient's everyday life. And a major role of the OT is helping prevent crashes and clinical deterioration. Many patients, especially those with ME and post-exertional malaise or PEM, have spent years pushing through symptoms, often worsening their condition. So the OTs can help them teach pacing, energy management, and how to recognize limits before a crash or prevent a crash by limiting activity. They help translate they also help patients adapt daily activities and environments to reduce physical, cognitive, and orthostatic strain while improving safety, function, and quality of life through practical supports like assistive devices, home modifications, and workplace or school accommodations. Physiotherapy can also be very beneficial in these conditions, but rehabilitation approaches must be individualized to the condition and the patient. In these patients, in patients with a diagnosis of long COVID, fibromyalgia, and POTS, post-exertional malaise is critical to assess for in cases of ME, in case ME is comorbidly present. In the cases where PEM is present, caution needs to be taken because as you may recall, repeated episodes of PEM can lower overall baseline level of functioning. For POTS, PT often focuses on recumbent or modified exercises and careful autonomic monitoring. Actually, they're using smartwatches for a lot of this right now. And for fibromyalgia, gentle movement and consistent activity can improve pain and function, but pacing remains important. The overall goal is to help patients maintain or improve function safely within their physiological limits. And social workers are critical because these conditions often affect more than physical symptoms. They also impact finance, relationships, identity, employment, and daily function. Many patients have spent years being dismissed or misunderstood within the healthcare system. Simply being believed and validated can significantly reduce distress and isolation. They can help connect patients with practical supports that can make daily life more manageable, including home care, meal delivery, transportation assistance, and peer support networks. And importantly, they can help patients learn to navigate the healthcare system while respecting their energy limitations. They can also frequently help families understand these invisible disabilities, which can reduce conflict and improve support at home. And the goal here is to help patients build stability, coping, advocacy skills, and the best quality of life within their functional limits. So we've come to the end of our presentation, but before we give our final takeaway points, it's time for us to return to our cases, Kat and Bridget. Our first case, Kat, well, this is actually my story. Like many patients with ongoing symptoms following an acute infection, I initially believed that if I pushed harder, exercised more, and stayed determined, I would recover. And some of my clinicians, they told me to exercise my way out of the fatigue. I kept working full time and I pushed through, then crashed and spent weeks in bed afterwards with profound fatigue and pain. And I often felt like I had been hit by a truck or a bus. You often hear that from patients. At the time, I didn't understand this wasn't deconditioning or a lack of effort. It was post-exertional malaise. Over more than 5 years, I underwent extensive medical workups with neurology, rheumatology, infectious disease, and sleep medicine. I had extensive workup, blood workup, CT scans, MRI, EMGs. They all were essentially normal. Because the tests were normal, anxiety was suggested as an explanation by primary care. And this actually happens to many, many patients with ME and fibromyalgia. In reality, what was happening was a post-viral illness that evolved into ME. It took more than 5 years before I finally received a diagnosis of post-viral ME. By then, I had already spent years unknowingly worsening my condition by pushing through symptoms and following conventional advice to increase activity. And I just want to mention here that I was a nurse. I had, and I was working in a not-for-profit that a humanitarian aid organization in Toronto that I had access to infectious disease and public health colleagues. And that's something that most patients obviously don't have. And it still took me 5 years to get a diagnosis. So, and before we, I just want to mention too, but before we move on to Bridget's case, it's very important to note that in Ontario, physicians providing care for patients with ME and fibromyalgia, they have the option to book a longer appointment and can bill, if in a billing model, the K037A service code, and that's the code for care of patients with ME, CFS, and or fibromyalgia, and it's a time-based fee code. And moving on to Bridget's case. Bridget's case demonstrates the importance of looking beyond fibromyalgia alone and when patients present with significant fatigue and multi-system symptoms. So the first step was to confirm the diagnosis of fibromyalgia using the 2016 ARC criteria. However, as a reminder, it is critical to recognize that fibromyalgia and ME frequently overlap, and many patients diagnosed with fibromyalgia may also meet the criteria for ME. And as discussed previously, a clinical point is this: if a patient's fatigue is anything more than mild, clinicians should actively assess for ME rather than assuming fatigue is part of fibromyalgia. In Bridget's case, further assessment identified several core features consistent with ME. She had debilitating fatigue persisting longer than 6 months. She had post-exertional malaise, or PEM. She had unrefreshing sleep, and she had cognitive dysfunction. So assessing for PEM was especially important as it's a hallmark feature, distinguishing ME from other chronic conditions. And the DePaul PEM questionnaire, which is in the CEP tools, is very helpful to identify that pattern. So for this reason, pacing became the priority intervention for Bridget. And once pacing strategies were implemented, Bridget experienced meaningful improvement in severity and frequency of pain, fatigue, and other symptoms. And it does take time, though. I just want to say that to get good at pacing, it takes a lot of trial and error, and it doesn't happen right away. But this case highlights how recognition of overlapping ME can substantially change management and improve patient outcomes.
Great. Thank you, Kathleen. So we're almost at the end of the presentation. Next, we're just going to review a couple of key takeaway points, and then we will have a bit of time for some questions. So in terms of takeaways, first one is ME, fibromyalgia, and POTS are interconnected and overlap and are commonly comorbid, as we said before. Secondly, before implementing a management plan for fibromyalgia or POTS, one must screen for common comorbid conditions such as ME, again, because it changes management. Thirdly, so in the patient with fibromyalgia and ME or POTS and ME, pacing must be prioritized with the goal to stabilize energy and avoid states of PEM. Fourth, interprofessional care involving OT, PT, and social work is essential to support pacing, function, symptom management, mental health, daily living, and helping to support improving quality of life. And finally, primary care clinicians and interprofessional team members have a central role in diagnosing and managing ME, fibromyalgia, and POTS. And the CEP tools on these three conditions is a new resource to support primary care clinicians. And just quickly in terms of revisiting the clinical references. So again, this is the landing page for the Center for Effective Practice Tools and highlighted in yellow. As I mentioned earlier, there is a patient and caregiver resource, one for fibromyalgia, one on POTS, and one on ME. And then there's also clinician resources with links to various tools, one again for ME, one for POTS, and one for fibromyalgia. So just want to say thank you for joining us today, and we'd really appreciate if you were to fill out your session evaluation. And I will stop screen sharing so we can have a bit of a discussion.
Thank you so much, Farah and Kathleen. Really appreciated the incredible amount of information that you've shared with us. I do have two questions that have come in on the Q&A panel, both from Alana. Her first question is, for ME, once energy management and pacing has stabilized the person, is there any way to then further improve or increase capacity?
So I can mention a little bit of that, and Kathleen, you're welcome to dive in as well. I would say the foundation certainly is pacing and getting pacing in place as a priority. After moving beyond pacing, once that's in place, there are off-label use of medications and supplements that patients sometimes will try. Again, there is no specific Health Canada approved treatment for ME, but there certainly are within the field, depending on what symptoms are present, that there are some off-label use of medications that can be tried. And really, whenever looking at something off-label that is not kind of widespread use, one needs to ask about, what's the potential benefit, what's the potential risk and side effects, what's the accessibility, and what's the cost. And then having that discussion, patients really need to be able to make an informed decision about whether that's something they would or would not want to try.
Thank you.
Can I just jump in there?
Oh, sorry. Yes, of course.
Can I just jump in and say, also looking at the other comorbidities, so MCAS, IBS, sleep for me because I had neuroinvasive West Nile virus that I did have sleep issues afterwards, and that made a big difference in getting control of my MCAS. And also, as Dr. Tabassum mentioned, there are what's it called, Farah?
Off-label.
Off-label, thank you, medications. And in the patient community, pretty much around the world, and especially in Canada, low-dose naltrexone is one of the big things, and that does help stabilize and helps patients. And there is information on that in the CEP, the pharmacological part of the CEP for fibromyalgia.
Thank you both for that answer. I'm going to jump ahead to a question from Andrea. She's saying she can't scan QR codes and needs a link for the evaluation. And just to reassure you and anyone else with the same question, Andrea, at the end of this webinar, the evaluation should actually pop up directly on the screen of whatever device you're accessing the webinar on, and will also be sent out as a link in the follow-up email. With that, I'm going to come back to another couple of questions from Alana. I'm going to go with her second question first. She notes that there's a lot of overlap with symptoms of perimenopause and menopause. Are there any pearls on how to differentiate between that and these conditions?
I think it can be quite tricky. But, in the woman who is going through perimenopause and menopause, typically we won't be seeing the breadth and constellation of symptoms that we see in a diagnosis with an ME, for example. Like you won't be seeing post-exertional malaise in, the woman who's solely experiencing menopause-related symptoms. Having said that, though, a lot of the women are within that age range where we know hormones are fluctuating and women are going through perimenopause and menopause, and certainly addressing that along with, addressing whatever other comorbidities come up along with ME. I think addressing symptoms of perimenopause and menopause are equally important in this age group.
Thank you. And another question from Alana is, are there any suggestions for how to access an interdisciplinary team that's knowledgeable about these conditions and is available, accessible, and covered? So, you did such a great job of showing us the value of that team, but how can say a physician ensure that their client can get access to the care from all these different providers?
Yeah, well, for sure, if you're in a family health team or a community health center, I believe that there are those resources. But for others, Ontario Health at Home would be another way to access them, because they have you can get a caseworker involved for somebody, and they can actually get PSW help. They can get community care involved, so you can get a caseworker involved that way. And then there's also some really good support groups that I would say for patients to join, that they can learn a lot from and get support that way as well. If you give them the CareNow or the MEFM Society of BC has excellent community support and networks that way. For I would say also for occupational therapy and for social work, they're already trained to be working with people with decreased energy and fatigue from MS or ALS or that. So it's very similar in them helping those resources and helping them get access to ODSAP or the CCCP as well. CCCP? Yeah, that's right. I hope that answers your question.
Thank you. Andrea is noting that not all CHCs have the same resources.
Sure.
However, I think with the increase we're seeing in regional and local collaboration amongst different healthcare providers and organizations, we will see, hopefully, better access to interprofessional providers. And there are programs such as Team Care, in which those CHCs and family health teams who have more of the interprofessional providers are sometimes able to make them accessible to other providers in the community. Seeing another question from Andrea, who's asking, is there any way of sort of identifying who might develop post-viral ME or post-accident fibromyalgia and preventing the development of those conditions?
I have not seen any specific medical literature on prevention. I know for long COVID, there was some research out there in terms of identifying who may be, or who are people who may be more prone to developing longer term symptoms. And typically there were other kind of metabolic issues going on or more severe episodes of acute COVID. But, you know, at the end of the day, we also know that people who had next to no symptoms, some of them still went on to develop long COVID as well. So I haven't seen any good data in terms of prevention.
Thank you. I'm sorry, go ahead.
I was just going to say that I mean, I worked overseas in many different areas, and I got bitten by mosquitoes there. I got bitten by all sorts of things, and I got many different other conditions. But you know, I was quite stable and out of working overseas for over 10 years when I got bitten by a mosquito in my backyard and got West Nile virus.
Thank you. There are a few other questions that have come in. However, it is 1:02 p.m. Those who want to stick around for a few more minutes, I think Farah and Kathleen have graciously offered to stay on a little longer. I'm going to do a quick screen share just once again to show you the QR code for those who are able to access it, to take a moment to evaluate the webinar. But while that's up, we'll continue asking some of these questions. So another question from Alana, any guidance on how to apply for ODSP or other disability programs for patients or clients who are living with these conditions?
I think the patients have to apply for it themselves, and then it's for the physician to, if you're a physician, to support the application. But there is ODSP, but there is also some people have long-term disability, and some people have access to CPPD, Canadian Pension Plan disability, and also things like disability tax credit. And it's the physician's role is more to support and to describe the patient's condition in terms of activities of daily living. I assume that's how you do it, right, Farah?
Yeah. And really focusing on, you know, has the condition been severe in terms of what's been the impact on the patient's life in terms of function, as well as, you know, not only occupational, but social and you know, activities of daily living. And then looking at, you know, has the condition been severe? Has it been prolonged? And really kind of describing, you know, the impact of having this condition on their life.
And social workers and OTs can both help
Documentation. Mm-hmm.
with that as well.
Yeah.
Thank you. Got a question here from Jeanette, who is a speech language pathologist, I believe. And she says that she sees many clients who are diagnosed as having chronic fatigue and anxiety from a variety of people, but none of the measures described in this webinar have been used for diagnosis. And so I guess as an interprofessional provider, she's wondering how she can describe that in a report to help them get the diagnosis they need.
So I probably want to make a clear distinction between chronic fatigue, which is a symptom of many different conditions, and chronic fatigue syndrome, which is an outdated term, which refers to what we now know is myalgic encephalomyelitis, ME, which is a specific medical condition defined by the unique symptom of post-exertional malaise. And so, kind of keeping that in mind, not to kind of mix the two together, I think is really important. And that may be one reason why some of these modalities haven't been seen in other conditions, because the chronic fatigue may be rooted in a different issue than the chronic fatigue seen as a symptom in ME.
What would you suggest for an interprofessional provider who's seeing clients who maybe have some of these symptoms, have maybe been, misdiagnosed with anxiety, or had their symptoms described as chronic fatigue without actually a diagnosis of ME being pursued? So now you have an interprofessional provider who's seeing this person who maybe recognizes some of this. How would they go about, getting the assessment done by a primary care provider for that client?
Yeah, that's such a great question, because I do think a lot of interprofessional providers are in really strategic roles, and there's such an opportunity there for them to identify, hey, could this be ME? Should this be part of the differential? And having resources to either give to the patient about, hey, did you ever speak to your doctor about this? Just wondering what they think about it, or even if you're working within a team, bringing it to the doctor directly as a kind of a shared team case, that even referring them to the Center for Effective Practice Tools, which nicely kind of outlines what's the history you'd be thinking about, how do you describe post-exertional malaise, how do you make the diagnosis, just to put it on the radar of the primary care clinician as well as the patient.
These tools are specifically made for Ontario primary care, so nurse practitioners, physician's assistants, primary care clinicians, and as patients, we have been feeding them into primary care. We are literally taking them or sending them to our clinicians. So that's one of the main ways, is that get these specifically, and these tools were actually developed by the Centre for Effective Practice, but funded by the Ontario Ministry of Health. So that actually has a lot of credibility to it. It's Ontario, a Canadian tool that's specifically made for primary care, and patients can take this tool or send the link to their physicians as well, because this was made for them.
Thank you so much. And we have just one last comment remaining in our Q&A, which is Jeanette again saying that she does see a lot of long COVID patients with excessive fatigue. So perhaps an indication there that there is more investigation needed into whether they have, one of these ME.
Yeah, I mean, I do want to comment on that, because I think when the pandemic first started and it was being identified that patients were experiencing longer term symptoms, and they kind of went under this umbrella of the term long COVID. So long COVID essentially refers to any symptoms that persisted beyond 3 months, new symptoms or persisting symptoms beyond 3 months. So it's quite a big umbrella. But within that big umbrella, there is a subset of them, which I mentioned before, up to 50% of them were meeting criteria for ME. From our perspective, of those of us who work in the field of ME, the difference between the long COVID patients and ME patients that we saw before the pandemic is that the long COVID patients who meet ME criteria, it's an amazing research opportunity, because we know exactly which virus triggered ME in this case. Whereas before the pandemic, we didn't have access to widespread testing for viruses. So all we know is that symptoms of ME started after a flu-like illness or some sort of infectious illness. Whereas with those who developed long COVID that meets criteria for ME, it's an opportunity to do more research, because we know exactly which virus triggered the symptoms of ME.
Thank you. And with that, we have come to an end of our open questions. So again, really appreciate both of you, Farah, Kathleen, taking the extra time to stay online, and those attendees who were also able to extend their time and stay with us right until the end. I really appreciate everybody who was able to join us. Once again, we will be sending out an email in the next few days with the slide deck and a link to the video and just a little bit of a summary of some of the things we learned today. So I hope with that, I wish everyone a wonderful rest of your day. And please do take a moment to fill in that evaluation survey. Let us know, how well this webinar served your learning needs, and if there's anything else that you would like to learn about related to these conditions. Thank you so much.
Thank you, Catherine. Thank you to the Alliance.
Thank you, everyone. It's been a
Bye.
pleasure.
Bye.